Here she comes. Here she comes. There's always one. There is always one. So I hope you guys can hear me. Right, I get the task of standing between happy hour and happy sunshine. So before I do that, I think you all should give yourselves a round of applause. It's been a long day. We put you in a room without windows so you could not be tempted by the beautiful sunshine that's outdoors today. So for that, I quasi-apologize, but it was all a part of the strategy to keep you focused. So we have the awesome task this afternoon of really facilitating or leading this action framing conversation. And I would say that if you look at the notes for the people on this panel, they could easily be the proceedings from this meeting. They have been very astute in listening to everything that's been brought forward today, and we're going to do our best job of really trying to bring everything home in a way that becomes very actionable. As a part of that, what we really want to do is answer the question around bringing home this culture change that we talked about. And when we started out the day, we talked about this whole framing around the socio-ecological model because we realized that there is a role at each sphere in that model for everyone to play, from the individual that's at the core of that model all the way through to society and policies and relationships and organizations, et cetera. And we really want to highlight what are those great opportunities at each sphere. And whether you are a patient, a provider, a payer, or a producer, the role that you can actually play in really helping to change the curve, and more importantly, begin to address this whole concept with the whole principles of social justice in mind. So with that, I extend this action framing panel to our in-person audience and our global audience. We're worldwide. In the Twitter sphere or the atmosphere or the sociosphere, wherever we are, to really engage with us as our panelists this afternoon share their perspective. We invite all of you to think about actionable activities and steps that you or the organization that you represent can actually adopt to advance adoption and implementation of the strategies to improve access to equity care for persons with serious illness. So to help us get this conversation started, I have the privilege of being the moderator for the Fabulous Five. Oh, come on. I know it's five. Come on, come on, come on, come on, come on. All right. Coming to the field. I'm just kidding. So first we have, of course, Daniel Dawes. So Daniel is the Executive Director of Health Policy at Morehouse School of Medicine. And of course, details of all of our speakers are in your bio, so in your briefing booklet. So I want to make sure that I highlight, among his many achievements, he was instrumental figure in shaping the Mental Health Parity Act, the Genetic Information Non-Discrimination Act, the Americans with Disabilities Act Amendments Act, and the Affordable Care Act. But he is not an act. He is truly a real person. And so please be prepared. Be prepared for our remarks from Daniel. And also following Daniel is none other than Steve Clauser, who is the Program Director at the Healthcare Delivery and Disparities Research Program at Patient-Centered Outcomes Research Institute. We now know that as PCORI. He is responsible for delivering PCORI's research program that evaluates comparisons among alternate health system strategies to improve patient outcomes in a broad range of clinical and organizational domains. And bringing up our Taylor, our ladies on the group, we have, see, the first time, the men got to go first. Where else does that happen than at 4-something on Thursday? All right. So Nadine Barrett is assistant professor in the Department of Community and Family Medicine at Duke University School of Medicine. She's also director of stakeholder engagement for REACH Equity, Duke's Health Disparities Center of Excellence, and the Equal ACP, which means Advanced Care Planning Study, a PCORI-funded research project designed to reduce race disparities in advanced care planning among older chronically ill patients. And bringing up the rear is none other than our awesome co-chair, Peggy Maguire. Peggy serves as president of Cambia Health Foundation. Peggy works with a wide range of stakeholders to drive healthcare transformation that results in better experiences for people and families. Under her leadership, the foundation has evolved from a regional grant-making organization to a purposeful investor in person-centered, economically sustainable solutions. Please welcome our panel. So the way that we're going to start this afternoon is I'm going to ask the panel a series of questions, and they have an opportunity to respond to those questions. And starting with Daniel, my very first question is around, so we've heard a lot today, we've seen a lot. So when you think about what you've heard, what you've learned, what are some key issues or some key themes that have really resonated with you from today's presentations?
So, Shonta, I want to thank you again for that very generous introduction. And actually, before I answer that, I just want to thank the National Academy of Medicine for truly being a leader in advancing health equity and helping us to prioritize this in health policy over the last 40 years, in fact. So with that, wanted to highlight about 7 themes, issues that I heard today. First one being that health inequities occur throughout the life course, and the best solutions to health inequities should come from the most adversely affected. They should employ an ecological approach, a broader lens, as we heard Diane Rowland mention earlier, and leverage peers, ensure access to high-quality communication, as Justin discussed, and build partnerships at all levels, because the health sector cannot singularly do this, as Edward mentioned, to address the multiplicity of needs and enhance trust. That was the first one. It's like a whole bunch in that one, right? And the second one, and I have about 20 pages of notes that I took all day if you're interested. We live in a complex ecosystem where communities are at the epicenter of health equity. Place matters, or as Marshall mentioned, context matters. Therefore, communities must be empowered to tackle the multiple, intersectional, mutually reinforcing determinants of health inequities. The third theme that I got today was that power, leadership, and relationships are the currency for achieving greater health equity. Therefore, we all need to work upstream, integrate our approaches to tackling the social, behavioral, and political determinants of health. And as Sister Ann discussed, the need to create or secure the funding mechanisms to sustain many of the innovative, evidence-based, or promising programs that are moving the needle towards health equity. Fourth one is health equity is a moral, cultural, civic, and humanitarian imperative. How do we effectively unearth the issues and then ensure there are interventions in place to address these? The fifth one is, how do we begin to build the capacity of our workforce in rural, frontier, and urban communities so they understand the role that trauma plays in the access, delivery, and adherence to healthcare? And then 6 and 7 are truly combined. And, we heard from Bridget earlier today. And she talked about how in the last 18 years, it didn't seem like the healthcare system had changed very much. When we look at accessibility and diversity of clinical trials, much hasn't changed, right? Both she and Kimberly discussed the challenges of accessing clinical trials. Phil Pizzo acknowledged in his remarks today that even the medical curriculum hasn't changed in decades. And when we look at the delivery of care, the workforce hasn't changed much, and in some respects, we're regressing. And regressing in the specialty areas that impact communities of color and other disparate groups. As Darcy emphasized as well, equity is fundamental to quality, and yet, as Marshall emphasized, there's a dearth of public and private policies prioritizing health equity. Many of you have been leaders in authoring and publishing over 6,000 peer-reviewed journals on the topic of health equity, minority health, health disparities, and yet we've only been able to achieve piecemeal public policies around this. From a policy standpoint, we haven't done enough to move the needle, and I would really push us to continue focusing on developing and implementing actionable and meaningful policies that utilize an equity lens. As Kimberly also discussed, we need programs, policies, and systems which accommodate a range of beliefs, values, and concerns that are critical because a one-size-fits-all approach does not work to address inequities. Policies impact health, as Liz mentioned, and we have to move on action, as Darcy stated. My final point, then, is The pursuit of health equity will be disruptive, it's uncomfortable, and it's threatening because the issues are so ingrained in our system, as Bridget mentioned. And as Edward discussed, we as a health sector feel like we need to step up and play our part to overcome the disparities, and we can't solve all of those problems by ourselves, but we need to strategically focus our work and our advocacy so we can leverage all of this work that is before us. So I will end those, but those were the themes that I had heard and seen. So after you.
Steve, same question.
Okay, well, I'm kind of a glass half full guy. So I look for the positive. And I thought one thing that's really positive is that this whole day has been incredibly engaging. And most of the times when I go to a conference that has a broad issue like serious health disparities is on the second day. It's the second to the last session, and half the people are gone. And I think this demonstrated the importance of this topic both for the nation and that there are real opportunities to make change. And I come from a research perspective, so I thought that Marshall set the tone well, that there are evidence-based interventions out there. We've learned a lot about how to tailor education for patients and providers in a number of areas. And in the areas of changing healthcare teams, there has been an incredible amount of work done to try to advance the utilization, particularly of peer navigators, which I agree are one of the most powerful augmentations to a care team for many of these issues, but also community health workers more broadly with the work that Adrian pointed out in his, not only in the traditional sense of communicators navigating patients in a care coordination fashion, but also taking on new roles to educate and improve community health, which I thought was very, very exciting. Now, one of the areas also that I think is challenging, there were several references to rural health, which when you take many of these disparities, you actually kind of compound those disparity statistics when you look in rural areas. One area that is an area where it wasn't discussed much from a research perspective, it's not surprising, is the role of technology. This is an area where, in spite of probably dozens of systematic reviews, there's constantly references to gaps in evidence regarding how we deal with health literacy, racial and minority populations, other kinds of special issues that these populations face. And technology is one of the things in more the recent studies that are really becoming part and parcel of that kind of complex intervention package to try to improve health equity and reduce disparities. And I think that even though it wasn't a focal point of this workshop, it's exciting because in the next year or two, there's going to be a lot of evidence coming out in that area that I think is going to really benefit us. I mean, one of the challenges, I think, in this area is that when you really look at the literature, in spite of all these interventions, it's the complex interventions which seem to have the biggest impact on outcomes, and that, quite frankly, shies payers and people who have to put resources on the table away, because this is a real intensive effort in order to try to move the field. And I think one of the discussions that kind of came through a little bit with the payers and what we've heard from payers and patients who sit down together is, we talked about the issues about, more generic solutions and how those aren't appropriate for, disparity or vulnerable populations. Also, we need to know that vulnerable populations are just as diverse, and they have many different kinds of reactions. And we need to have really more specialized studies that can allow us to look at almost dose effects of some of these types of interventions, disassemble these complex interventions, and find out what interventions work best for whom under what circumstances. Because that's not only going to provide benefits to patients who don't necessarily need additional interventions, but it's also going to allow potentially having resources to be able to target to those populations that we know are going to need complex support in order to move, but it'll enable us then to have other parts of these populations that maybe only need agency of patient education and the right materials at the right times, like in Bridget's situation, or maybe just need this information in different ways communicated for younger populations through the web, because that's what they do every day, because 80 to 90% of them do have cell phones and have iPhones. So those were some of the issues that I thought were important. The one area that I think is still problematic for us, I think, that I heard in the area that has a research implication is this issue of how to address discrimination. Because we heard from Bridget that this notion of institutional discrimination is real. It's uncomfortable to talk about. And we heard some very exciting things about training providers to be able to, address some of these cultural issues in terms of kind of both implicit discrimination, but that we can draw from some other areas that have really tried to look at this much more fundamentally. For example, in the area of pregnant women and low birth weight for individuals who are low income and women who are of mixed race and diversity, there has been an international effort to develop actual measures of discrimination where it enables providers to actually get those perspectives directly, to think about transferring those kinds of measures into this area might stimulate quality improvement efforts if you have, as Marshall says, the leadership of the organization that is committed to doing this and the wherewithal to do these kinds of quality improvement efforts seriously. So I think there is opportunity there, even though it was a very difficult area to try to get our hands around today. So I'll stop there.
Nadine.
Excellent. Wow. Well, after hearing the two summaries, it's been an amazing day. And again, thank you most certainly to everyone in the planning committee for putting this together. It is a great opportunity, especially when I think about where we started this morning and just how powerful it was to have Bridget really share her story. I think really just couching anything that we do with the patient experience and perspective is so critical because it reminds me anyway of why we're here, why we do what we do. So that was absolutely wonderful. I also feel like there were certain areas where, for example, the video with Jay, that was a powerful video, incredibly compelling, and I think it highlights a number of factors, not just in communication, but just in terms of how do we ensure that our health systems are set up in such a way that we can provide the type of care that values everyone and that everyone feels respected. And so I think having those patient perspectives were just so rich and so meaningful and keeps us grounded, if you will, throughout this whole day in this dialogue. So again, thank you for adding those pieces. So for me, there are several things that stood out to me. I think that there was, without a doubt, this whole conversation specifically around training and what does that actually look like. And so the training seems to go across the gamut, right? Everywhere from a lay person to a patient, community health workers to the health professions, doctors, nurses, et cetera. And so when we think about that training, there were several things that really stood out. One, I think, and I have to start off here with Marshall's comment because I absolutely loved it, this whole idea of fearless conversations and dialogues. And when we talk about training, oftentimes we don't put training together with fearless dialogues and conversations. But if we're really going to talk about health equity, we cannot talk about it without acknowledging both the historic and current experiences that most marginalized, vulnerable populations are dealing with. If we don't acknowledge that and recognize that and ensure that people know that, then we're really just kind of putting a Band-Aid over a wound that still exists. And so I think that that was a key part of that. Part of that dialogue was certainly around implicit bias training and what that looks like. There are a number of trainings that are out there now around implicit bias, and we're still trying to figure out what actually works, but even more importantly, what is the knowledge and the skills that people actually need to be able to address that interaction between them and that patient to ensure that people are getting what they need. And I think that that's a critical part with that and in that dialogue as well. That also dovetails nicely with a number of other things. One, I think, is certainly thinking about the communication component. What does communication look like, and what kinds of trainings and support and system efforts that need to be in place to ensure that that conversation is happening in a way that's meaningful and, again, ensures that patients' goals, particularly around those who are seriously ill with chronic disease, are getting a need. The other part that really stood out to me is this idea, Dawes, I think you mentioned it, around culture and what language are we using today? Cultural sensitivity, cultural humility, cultural responsiveness, sensitivity. all kinds of things. And I could not, when you went like this, I was just like, yes, how many more words are we going to keep throwing out there to describe the same phenomenon that's been around for centuries? And so the idea is that, and I love this point of how do we move to action, and I think that that's critical too. Part of that in terms of even training, how do we help to incorporate in training not just the awareness and the knowledge and the skills and the strategies, but also the forward moving. And I think that someone talked about that too in terms of the difference between knowledge and raising awareness and the commitment to actually make a change in our interactions, our behaviors, and what we need to do from an individual level all the way through using the ecological model to the from the individual to the system and through policy. So that was one. I follow the leader. that was point one.
Just like
You can see they were paying attention. This is a very competitive group.
Excuse me, couldn't resist.
This is all from this morning,
Exactly.
from today.
But the last few I'll make very simple because I think others have mentioned this in different ways as well. So at Duke, I'm the Associate Director of Community Engagement and Stakeholder Strategy, both for the Cancer Institute as well as for our Clinical Translational Science Institute, which kind of really looks at all kinds of diseases and how we actually create the appropriate strategies and partners toward moving work forward. That position came because before that I was the inaugural and founding director of the Office of Health Equity and Disparities at Duke and the Cancer Institute. The part that people talked about specifically around leveraging partnerships, I think is so critical because I think we don't take enough time to step back and think about what is it that we need? Who are the partners that should actually be at the table for us to develop what that should look like? And sometimes when we think about the partners, we tend to go to the same culprits and not stop to think about who are some of the actual innovative groups that we need to be engaging on a regular basis? Who are the people in our communities? Who are the people that can also help us to think about, I think one of the themes here that wasn't really a theme, but it was something I kept noticing was the language and the words that we were using. And some of the words that we used even to explain or describe some of our programs actually could, depending on who it is we're talking to, could actually be offensive, right? Even though well-intended. So who are the people that we're engaging throughout that whole process, from the beginning of developing an idea all the way through to the execution and evaluation of it, even the naming of it? How do all of those things actually really play out in understanding diversity, understanding disparities, and also recognizing that language matters, words matter, and they make a big difference. And that was a theme that I picked up in different ways. No one have any fear. I'm not going to come and tap your shoulder afterwards. Okay, I might, but totally out of a good intent in terms of really thinking about how we can actually make those changes. And then the last two things is that there's no need to reinvent the wheel. There's some phenomenal ideas that came from today. I think one of the challenges that we have nationally, especially when we talk about evidence-based programs and projects that we want to implement locally, is that we really don't quite get how do we actually do it. What does that look like? So we could read an article in a journal that tells us about this great evidence-based practice, how they did it, et cetera, but the details are not there. And that's really where the nuts and bolts and the change happens, especially as we're going to adapt it to our specific communities. And so I think that that's one opportunity that we have here. Great programs. How do we actually really bring it to our own neighborhoods and our own homes? We have some great examples here with the Heart of Hearts, for example, as one. And then the last two, patient outcomes. This was really, again, just really highlighting the importance of patient outcomes, goals, and culture. And again, I can't reiterate enough that the importance of that communication between providers and anyone actually within the healthcare system and patients. How do we ensure that that training looks appropriate, that training for medical students are appropriate? I think that those are critical. And I think that that creates an opportunity for that kind of skills building training. But I think a part of it, as it was mentioned before, is that all of these things have to happen in some way within a system that already acknowledges that health equity exists, that we need to actually make a difference and we need to change it. We need to think about even things like quality improvement measures. How do we move quality improvement measures and put a health equity lens over that toward really ensuring that people are having the best health possible? And that's it. I'm excited for where we can go from here. Thank you.
Okay, it's hard to go forth and not be repetitive, but I am confronted with the fierce urgency of now. Thank you for that quote, Kimberly. And really based on Bridget's story, how we started the day, that her experience shows us that we haven't moved the ball very much in 18 years, and that's unacceptable. So that creates this urgency that we need to change the way we're doing things. And as Marshall said, there's no magic bullet, right? That one size doesn't fit all, and each community is different, and interventions that work in one community may not necessarily work in another. And I think that solutions have to be built with the voice of the community in mind and taking that into account. Trust, I think, is absolutely essential to be able to find solutions. And I think trust starts with personal responsibility. So taking personal responsibility to recognize our own biases and our own backgrounds and how we present in these conversations, and then really to acknowledge I think Marshall did a great job of walking us through the history of colonialism and structural racism and some of the factors that we really need to acknowledge and as part of our healthcare system. Kimberly provided evidence that palliative care reduces disparities in care, that it is an effective intervention for reducing disparities. And, as I listened to these conversations, I thought, what are the things that I can personally influence from where I sit at Cambia? So in addition to serving as president of the Cambia Health Foundation, I have responsibility for integrating palliative care services across our family of companies. And Cambia is a non-insurance, nonprofit holding company that houses a number of companies within it. So we talk about our company as being in pillars, and we have our foundation is one pillar of Cambia. And through that pillar, we've invested about $36 million to advance palliative care, quality and access, and workforce development. Through our regional health plans, we have 7, and now we've just announced an affiliation with Blue Cross Blue Shield of North Carolina. I think about we have a health plan benefit that provides access to palliative care services. The interesting thing about that is even though we introduced the benefit in 2014, the uptake of it hasn't been as robust as we would like to see because I think we need to work on the network side. And I think what we're working on now is financial incentives and I really love this idea of measuring equity as quality, treating it as a quality measure, and financially rewarding quality and equity in our value-based arrangements. I think also that as a payer, we have the ability to influence the social determinants of health and whether those are being addressed by our provider organizations. And I also, think that we need to begin thinking about trauma-informed care and how do we, in our system, exert influence over training and awareness about those issues. Let's see. Workforce, I think, was a big issue that came up today, starting with how we educate clinicians to be compassionate, caring, and treat the whole person as opposed to a person as a vessel of disease. I think I was struck by the lack of diversity that Kimberly talked about in terms of the clinician population. Only 5% of physicians, I think you said, were people of color. So I think we need to think systemically about how do we change those numbers. Really, I continue to think that fostering a team-based approach in the workforce is really important to continue the training with communication and then extension with community health workers. And then finally, I think we heard that advanced care planning throughout the day was kind of throughout the day, but that advanced care planning is really important, but it has to be appropriate to the person and appropriate to the community. And I too loved the card game that you showed us. because I think the Conversation Project, I don't know if Kate's still here, but that the Conversation Project has done so much to think about how do we translate concepts to different populations. So that's my summary, but no magic bullet.
So as you can see, our panel was actively listening this morning. And so the great task that they had is that this group had a test at the end of the day. So their test at the end of the day is, wow, we always hear about, here's the issue, here are the challenges. And I think someone posed a question earlier around, what are those very specific, what are those very tangible action steps? And so if we gird ourselves around the principles of social justice, which are access, equity, rights, and participation, and then begin to overlay that with the spheres of the socio-ecological model, what are those very tangible action steps that we need to take to move forward? Think about them in the context of short-term, intermediate, and long-term, because I do think the last panel pointed out some of those more longer-term things that may be policy-related that will need to take place. But if we really think about the immediate, the short-term, the intermediate in a couple of years, and then long-term, what are some very tangible action steps that we can begin to think about? And as you respond to this question, please feel free to bring in very tangible experiences from your own work that have been proven to have the potential to impact those with serious illness across this country that can be replicated and not reinvented. I'm gonna start with Peggy this time.
Okay.
We're gonna mix it up a little bit.
Well, I'll start with the foundation perspective, because obviously we have the ability to fund programs in leadership development and workforce development. And we have, through our Sojourn Scholar program, we've been investing in emerging palliative care leaders from across the country, from all disciplines of care. Each year we invest in 12 emerging leaders, when we give them a 2-year, $180,000 grant to do an innovative project in palliative care, but also to work on their own leadership development. And our hope is that by investing in those emerging leaders, that over time there'll be a critical mass of Sojourn Scholars that will influence serious illness care, but also influence healthcare delivery in general. Justin Sanders, who is one of our scholars, was here earlier today. He's here. Justin's here still. And we have a number of scholars who are working on health disparities issues, either from a communications lens or mostly through communications lenses. But I think that is one of the concrete things we can do, is continuing to invest in the workforce and leadership development.
Excellent. So one of the things, I'm going to just use an example of what we did actually when I started the Office of Health Equity at the Duke Cancer Institute. When we have an opportunity to create strategies, and I'm speaking from an organizational standpoint here as well as a community engagement standpoint as well. When I started the office, I was asked to put together a strategic plan within like 3 months or so. And I stopped and said, that's probably not the best way to put together this plan, because I really want to find out what an Office of Health Equity would mean to those who would be using the office, right? What kinds of resources would it need? Kind of using some of that community engagement, CBPR type of methodology. Essentially what we did then is conduct focus groups for almost a year, meeting with our community members, meeting with our community leaders, our health departments, our patients, our caregivers, meeting with our research teams, meeting with the leadership of the hospital and the health system, the Cancer Institute. And by the time we were done with all of these meetings and focus groups and interviews, et cetera, we ended up reporting back out to our community what we learned, right? And so we actually had a big community event. We had over 320 plus people that actually came to this event. It was so so diverse. Even some of the people from the hardly reached communities in Durham were actually there and in presence to hear about what we learned and what we're going to do. And what I did was unveil basically our strategy with all of the voices of those perspectives in it. And that was how we actually launched the Office of Health Equity. I say all of this because oftentimes when we start thinking about leveraging partnerships to address health equity, when we start thinking about, well, what are the needs and what are the issues, we tend to look very internal on what we already know or what we've already seen in the literature. And although those things are great to build upon, it makes us miss out on new things or important things that's happening from a community perspective or from a patient perspective that needs to be brought to the table as well. So as a result, we created a strategic plan, and with that strategic plan, we also had a community advisory council that's a member of 23 people that represent different organizations, both statewide, locally, and local even to the county level, as well as patients, caregivers, et cetera, that are on it, and some of our community-based and community-rooted organizations in our area. And essentially, as a part of an incredible group, they actually worked together to develop and what we have now put into place, some of the models that were actually described today. So we have a full community navigation, community-facing navigation program where we're engaged with our community, with our faith leaders and our faith churches, with our different organizations, you name the organizations. We have a great partnership now with the Islamic Association of Raleigh, where all of the partners that we typically don't engage with, we have a full engagement, a full partnership with them, and in moving, and we actually move the needle in terms of asking them, well, what do you need? What's important to you? And I learned that from my mom, who's a nurse actually, who focused in geriatrics as well. She always had me at the age of 5 sitting down with her and going to nursing homes and say, don't talk to everybody, just listen. Stop, don't talk. And I really learned that it's so important to listen and find out what people need. And when we listen to tuning, we'll find that there's alignment in those priorities. We'll find that there are opportunities for actually to create bridges and opportunities. So through that process, through our Community Advisory Council, we were able to put together a full strategy that has 3 core areas. One of them is, as I said, community-facing navigation, which are community health workers who are from the community engaging with our community and with our patients, doing all kinds of work that's basically based on evidence-based approaches. And that's awesome. And in just that short amount of time, we also identify ways to do programs together. So we have men's health programs, et cetera. But the core essence of this is linking people to the healthcare system with people who are already, to your point, Peggy, trusted, people who already understand the nuances of culture, and not that it doesn't mean that we're free to not have to do the work ourselves, but it's a nice bridge to create that trust to address our immediate needs. The second area is we actually identified opportunities to diversify research and clinical trials, and then our third area is to identify ways in which to diversify our workforce. And so we have pipeline opportunities, worked with our local HBCU, North Carolina Central University. So when we look at all of these things, I'm not saying that we all need to do everything, but I am saying that from a strategy standpoint, it led to us being able to both provide training for the researchers that are there. I developed a program that we're doing called Just Ask, and the whole point of that, again, is based on communication strategies as well as implicit bias and how our own social cultural perspectives. I'm a medical sociologist by training, so I incorporate that medical sociology piece to help people understand how do our social cultural norms impact how we think, how we interact, how we react to different situations, and how that can play out in communication between a health profession and a community member or a patient in that space as well, and how can they implement the appropriate strategies to address it. But the whole idea of strategies and creating these strategies, identifying what there is, one, prioritizing what do we already know that exists, what can we implement in our own space and in our own work that could actually make a difference? And 3, who are the people that we need to not invite them to the table, but ask them where do they want to eat? And that's a really good place to start versus having the table set, the dinner set, the venue set, the restaurant picked, and then say, here, come and join me for dessert. Instead, let's start thinking even way before that and say, if we're going to partner, what is it that you need? What is it that I need? And how can we align those priorities? As a result, we have multiple programs that we do with our community partners, but our community partners and our advisory councils actually have their own partnerships that they've now formed, and they're all working together toward advancing health equity. It's pretty amazing, and now we're in the second phase of it. We just did a survey where we engaged all of our community partners around it. 2,315 people responded to this 91-item survey with our community partners. It was all with them, and as a result of that, we're using those data both to publish and to identify opportunities for improving health, but we also share that data collaborated with their community partners that actually use it. It's a capacity building opportunity. They actually use that data for their own work, for them to write their own grants. It's not even related to our things that were a priority between us. So that's the idea of being able to listen to hear what people's needs are and see what is it that we have to do any way that we could incorporate this partnership toward really advancing health equity. And so when we look at the African American, Latino, Asian, Muslim, Christian, Health Department, Lincoln, our local FQHC, all of those are partners in this work. And because of that, we've been able to formulate programs that are truly moving the needle in addressing health equity, health disparities, and addressing the issues of diversifying our workforce.
My next?
You're next.
Okay. You can tell that Nadine's on my advisory panel because this is for my program, so this is going to be very similar, but from a different lens. My one thing is really you've got to involve the key stakeholders in your work and whatever you're doing, particularly in research. The one thing that PCORI's tried to do is to, really develop a system by which patients, clinicians, healthcare leaders and payers are involved right at the beginning of the design of the study all the way through the end. So therefore, then they have an obligation with implementation. And that model, we've got some experience with that. But the story I want to use that I think is relevant here is we have quite a portfolio in the area of community health workers, and particularly as it relates to trying to look at strategies to reduce disparities in a number of diseases in a number of areas. And we had the idea that wow, how about if we bring our stakeholders together to talk about research in progress, not just final results, but also research in progress, the idea that maybe, particularly for some of those studies that are more earlier on, we might be able to do some modifications, add some additional data elements that would make them even more relevant to those particular communities. And we kind of expected, that we would get our patient advocates to come and, a few other organizations, possibly a Medicaid plan might want to come. So we thought it'd be about 20 people. When we put it out through our network, and we were deluged by payers that wanted to come to this meeting. And it was really quite amazing. And so we had to really kind of refit the thing on the fly. And they came to the meeting with a real serious intent. And this is both large managed care systems as well as large national payers. They really wanted to understand this business about community health workers. And because they were seeing that they're having more and more responsibility for population health. And it was quite an amazing day because we kind of split them up with the patient advocates and the others so they weren't all clustered on one side of the table and others on the other side. And it really became a very interesting discussion about them asking very particular questions about the kinds of information they would need to be able to make a judgment about this evidence in order to think about it in terms of their current policies and practices. And it really came down to such things as, well, what is the training for the individuals that are in these studies? Really specific questions around, how often do they actually touch these patients, and what is the time that they touch these patients, and what are the implications of that for the experience that patients have in these systems. And there was a real discussion among the patients and the payers about the kinds of outcomes that are really relevant. Many of the patients were talking about care experiences. A lot of the lines of things we're talking about here: respect, dignity, being able to enhance a communication process that allows them to express their needs and their preferences but yet still have full information on their options. Payers were more talking about utilization outcomes, things that really drive resource allocation. And I think that in the end, that we came up with some ideas not only that are going to enhance some of the ongoing studies we have, but have been very, very influential in thinking about our next generation of research projects in this area to make them more effective. I think our palliative care initiative has been well influenced by that. Kimberly, that we're really engaging stakeholders in that process very, very heavily. Yes. Yes. And also, yes, exactly. And I think that also our initiative around serious mental illness also and it's very relevant to the work we're doing here. And those, we hope to see the products of those really start rolling out over the course of the next couple years. And the other thing that we got, and this really gets to a point that Marshall raised about context, is the notion of doing clusters of studies, really to allow you to look at context, because this is an area typically where one drug isn't going to change the situation. It's the constellation of the accumulation of research that's going to really make change. And I think we're on the cusp of really having some exciting results that might make the field take a look at how to improve these processes much better.
So I'm going to take a different approach here, looking way upstream, right? And you heard me talk about the political determinants of health earlier. You all heard that term, right? And do we all believe that there's health in all policies, that these public policies virtually impact all aspects of our ability to achieve health equity? Anybody disagree with that? No? All right. So as we're pushing for more equitable policies, one of the things I wanted to really emphasize today is that, you know, we are seeing a trend among the courts. So from a legal standpoint, a policy standpoint, you know, the courts have really been pushing this notion that all that's happening, all of these inequities, this redlining, discrimination, healthcare, so forth, these are things that happen in the social sphere. So what does that mean legally? They're not then linked to a constitutional remedy, right? So we continue to push this notion of social determinants of health. And I do believe that many of these political determinants are being masked as social determinants. So I just wanted to put that out there for a minute, digest on that a little bit, because from a legal standpoint, we will have no legally enforceable remedy in terms of that. So voting rights, fair housing, affirmative action. We see the Supreme Court continuing to water down the protections from those laws in the 1960s and 1970s. And then what happens? They say, well, they're so far removed, right? They're so far removed from the inequities that we observe today, so therefore they're now in the social sphere. I'd like to argue that as you all continue in your research, as you are continuing to conduct studies, that you, as Nadine was mentioning from that historical vantage point, you continue to make the case for how those inequities are linked to a political or legal determinant. My biggest frustration, I know from many health lawyers who are health equity, social justice advocates, is that it has been really troubling for us to see that, you know, usually when you have a major study, groundbreaking study, here from the National Academy of Medicine, usually you'll see it in a dissent. Can't get these other judges and a majority to take it on. So I'd like to urge you all to help us with that issue. The other thing that I wanted to bring back, you heard me mention the fact that in terms of our healthcare workforce, they are regressing, and you know, in this never-ending battle for health equity, it requires, of course, not only a dedicated and culturally competent health roster of health equity champions, but it also, more important or equally important, is a diverse clinical and allied health workforce, which includes, of course, the community health workers as a key partner. They are the bridge into the communities, right? And I know that Kimberly, Aiden, Marshall, and Sandy discussed this issue. And all too often, the dire need for a diverse clinical workforce can be lost in the minutiae of the many health policy fires that we're all dealing with, right? So I'm here to tell you today that the push for diversification of the clinical workforce is not only an admirable cause to champion, but it's an essential one for every other health policy that you might support. Certainly linked with what we've been talking about. And more specifically, when we look at the issue of Black and Latino physicians, as well as other physicians from disparate groups, in communities of color, mistrust of doctors and the medical care system in general can run deep. We know that's very true here at Morehouse School of Medicine, where I'm at in Georgia. We know that in many rural communities, which are predominantly African American, this is an issue that keeps being raised. Many folks fear their providers still. Racism has reared its ugly head again, right, lately, and so folks are scared about these things. They're more likely to agree to preventive services and to disclose more information to their doctors, thus improving the trust of healthcare providers as we move forward. So we heard the statistic that, you know, African American doctors represent, what, 5% of the practicing physician workforce. But I also wanted to highlight another trend that we've seen, and it's the fact that in 2014, we had 515 Black males enroll in medical school. That's less than in 1978, where we had 542 Black males, right? So I would love to urge us to continue to tackle that issue. as we move forward. It is absolutely critical. We know it's also another issue with Latinos, and the fact that they only represent, 1% of providers in the U.S. That have an advanced terminal degree. So these are some of the issues that we are working on, and we'd love to work with you as well as we move forward. I'll end it there.
Well, I want to ask, so do we want to go ahead and open it up for questions? So why don't we go ahead and open it up for questions from the floor or any questions that we may have online? Are there any for our panel? I'm trying to get you the happier hour. No questions? You guys were so good that they just have no questions. We are the happy hour. But I do have one follow-up question for the panel. You know, based upon all those things that we just talked about in terms of examples and opportunity, if you had to think about those spheres of the ecological model, socio-ecological model, and if you had to choose, you know, if you had to say, okay, I think this action focuses on policy, community, organizational, interpersonal. If you had to identify specific action that could be taken at any level of that sphere, what would be that action? So if you really had, you know, if you got Bridget at the core of this, and you're thinking about Bridget, and you're thinking about those children that we saw on the presentation earlier from Sister Ann, and you had to say, okay, if those are the individuals, they're at the core. If we think about these spheres of influence, how do we begin to leverage whatever influence that we may have as an organization, as a national organization, as a community level organization, as a health system, as a payer, or what have you? What is one very tangible action step that you would set forward? They weren't this was a sneak in. Moderator's privilege.
Okay.
I think if there's one action immediately that could be taken is to encourage advanced care planning with all populations. And so to make, I would say use community health workers and churches to engage their constituents in advanced care planning conversations.
Well, go ahead, Nadine.
No. Let's break it.
Okay, we'll break it. So I certainly believe that telling your story is absolutely important. I wish we could bring Bridget with us to Capitol Hill to meet with our policymakers across the country. You'll come? All right, I'm going to take you up on it. So what we have seen when we monitor, as you all know from HELEN, we monitor the introduction of bills and other policies that advance or prioritize health equity. And we have seen a decline in the introduction of these policies, which is alarming to me. And we certainly need more folks to go out and tell their story, to explain what this whole issue of health equity is about. I think, especially in the South where I'm at, many folks believe it's a social, what do they call it? It's a socialistic idea, and they don't even want to hear it. How can we talk that language? How can we meet our policymakers where they are and continue to push this as a priority? I would certainly love to urge folks to get involved at that policy level.
So what I hear you saying is the actions that we can take to help individuals in our community who have serious illness be able to tell their story and curate their story to influence the narrative going forward.
No, I was going to say something very similar to that, because I think one thing we do in research particularly is just it's not accessible. It's not as touchable to the people that really, really are influenced by that research. One thing I think we need to do, and I think it's really important, the most powerful things today, we're not the statistics, we're not, the programs, quite frankly, it was the stories. When people said stories, everybody stopped working on everybody was focused, on what was going on. And I think from a research perspective, I think we need to get those stories out from participants who really benefit from those stories, consistent with what the research says. We've had example with people who have advanced Parkinson's disease who were in a telehealth study, and it was a remarkable statement. We brought a patient and the clinicians in to talk about their experience in having their provider kind of captive on that screen because they couldn't go anywhere. And it really helped them connect, and it forced them to have a real conversation, not just about the clinical issues, but about their life. And they got to know one another a little bit. And the opportunity of having that connection where they're both sitting there really made a difference. And the project found that there was really no difference in the physical outcomes between people who drove 25 to 50 miles, who are in rural areas, to their 20-minute appointment, versus being in a telehealth consultation for an hour with their clinician. And those results, aren't going to get you a New England Journal of Medicine. But it's those other outcomes about the savings and not having to drive 25 miles and the 4 or 5 hours a day you have to spend for that 20 minutes with your provider that's resulted in a dissemination plan now where we're working with the state that might actually make this service free for all Parkinson's patients in their state. And we're trying to work with the American Neurological Society to try to create a training program to teach them how to do this telehealth, therapy online. So, and I'd say it's those stories that really are the things that generated that interest as much as the results of the research.
And so, Steve, what I hear you saying is being able to leverage what our research tells us to really focus on building out that relationship and interpersonal sphere of the model. And how do we begin to institute that in a way so that patients and providers have that shared relationship? So really giving us an opportunity on how you can really highlight and elevate the importance of those interpersonal relationships that are the second sphere in the model.
So I think mine is actually on a very similar vein as well. It's really, for me, I think about access and quality, and I know that that's the basic theme of this whole day. But when I think about the word trust that you said earlier, Peggy, and what does it take to create a trustworthy system and a trustworthy space? So we talk about trust all the time, but the point is, how do you move from trust to trustworthiness, right? And a system and a health system engagement that's really about being trustworthy. And so I think that this community health worker model is great. I'm going to have to call out Dr. Kimberly Johnson, who's here, who has a study that's actually funded by PCORI, which is looking at community health workers and advanced care planning with 800 patients across 5 states. And I think that this study and this project is really a great opportunity for us to really think about how do we address health equity, particularly for African Americans, when we're talking about chronic illness, end-of-life decisions, and decision-making and advanced care planning. But I think that the beauty of it is that the storytelling, when we first met, I have the honor of actually directing the stakeholder engagement component of this study. And since it's a multi-site study, we have multiple stakeholder advisory councils. And so we created this model around that. And when we first met with the stakeholders and then with the community health workers, I think one of the other PIs referred to it as almost a spiritual experience, because we asked them, why are you involved in this study? Why are you here? And this is a research study with everyone there. Everyone had a story to talk about how either someone did have access to advanced care planning and how it made a difference for them and their family. Others who would talk about how they did not have access to advanced care planning and they saw how much their family member died without really getting the care that they wanted and probably certainly needed. Everyone had a story to tell. And it was so powerful and so moving. So the storytelling is so important for advocacy and all these other areas, but it's also important for the work that we're doing right now in terms of simply getting people access to that care that they need. Making sure that we create a trustworthy space that is being able to engage those community health workers in such a way that they get to both tell their stories, but they also get to be great key players in helping to move that word forward. The community health workers, for example, are from a variety of areas. Some of them are from churches who are already, and our stakeholder advisory council members, I think it was like by the second meeting, they were just like, well, how can we take this to our church? Can we kind of let people know within our organization, our congregations, about advanced care planning so that this can become the norm? So I think that creating opportunities for access, quality, trust and trustworthiness, and creating that moving to a space where we have a seamless linkage between communities and the health system for those with chronic illness is critical. And so whatever ingredients that needs to be, that we identify those ingredients. And I think the key part of that is creating trust and ensuring that we have a system that's ready and prepared to be able to engage with patients from diverse backgrounds in a meaningful way.
And so what I hear you saying there is it gives us an opportunity to think about organizations very broadly. And that there is great opportunity that helps, and this move from trust to trustworthy could be a very valuable bridge that brings both that community perspective and that organization together in a way that brings into the voice of the community, and not only bring into the conversation the voice of the community, but it has the potential to amplify. And in that amplification of that community voice, you begin to move from being just trust to a place of trustworthiness.
Yes, absolutely. Well done.
Very
What
good.
she said.
Yeah. That would be such a great place to end because it's very uplifting. But I just was thinking as we all answered the question about Andy Slavitt's comments about what does success mean, and this affordability question for people with serious illness. I think that we have to realize what an issue that is for people, and then how do we get at that as well.
Absolutely.
And I think that takes us to the top of our spear, which is really around policy. And I think there's also an opportunity to realize that there's a role for all of us, whether we are an individual, a payer, a producer. And when I say producer, I'm talking in terms of industry, pharma, what have you, provider, et cetera. But there really is a role for all of us to play to really get to the top of this spear, which is making healthcare not just accessible, but affordable and available to everyone. And so I'm going to ask one more time, do we have any questions from the floor, online, in the stratosphere? All right. Well, with that, I'm going to ask all of you, unless my panel, do you have, 1 minute of your closing thoughts. You have 60 seconds.
Well, I'll start with gratitude. I want to thank again all the speakers for being here and sharing their work and sharing their thoughts today. I want to thank the National Academy of Medicine and Science, and I want to thank the staff in the back of the room, Lori and Solera, India. I think it's been a really great day and just lots of thoughts circulating. So thanks, everyone. And Darcy, thank you for your leadership.
Yes. Here's your crystal ball moment. 1 second. 1 minute.
Wait, 1
1 minute. 1 minute.
1 second. Not overwhelming. I think, again, I echo what Peggy says. Thank you to everyone, Darcy, your leadership, and the planning committee. I think in terms of this work, I'm leaving here feeling optimistic. And I say optimistic, not being clouds in the sky or anything, but more because there were so many great examples that people shared about what they've been doing that's worked. And so it really, it created that space of, okay, we don't need to create the wheel, but we actually have some opportunities. How do we get that information, kind of catalog it, and be able to move it forward in actionable ways? So that was awesome. And I think the other part that really stood out to me today was the stories, the experiences that people shared that really just moved my heart and just reminded me again of why we are all in this work and why we're in this fight. And just to see the diversity of all of us in this room and those who are on the call, there's people here and we're ready to make a difference, and I'm excited about this meeting. I'm excited about what comes from it.
I'm also very excited. I think, the one thing that with many of the statistics that are thrown around is that, unfortunately with inequities in income and all the other issues, this is the big issue. This is the big issue. This affects so many Americans in our society. And this issue of, for example, we just raised this whole issue of kind of the financial toxicity of the system that is going to be a major driver, I think, for a change. And we are, I think, somewhat well positioned for that. I think we have research. One time we can say we actually have some research that we could draw on, and we have some research that's coming soon that I think is really going to help provide kind of some opportunities for evidence-based pathways to try to address this issue. And we have, and at least where community health workers are relevant, and we heard that word 100 times today, we have that workforce. That's the fastest growing health profession in the United States. So unlike, clinical psychologists and palliative care doctors, we've got a workforce to draw on if we can figure out a way to mobilize it effectively. And so I'm also very sanguine that we're going to be able to move in this area.
And so ditto that everyone said, but I just wanted to share a final thought from a dear friend, a mentor, one of my heroes, Dr. David Satcher, where he says that in order to eliminate disparities in health and achieve health equity, we need leaders who care enough, know enough, have the courage to do enough, and who will persevere until the job is done. Thank you, everyone.
So that means no retirement
that's all
for
of
anyone
us.
in this room anytime soon. So, sorry. So as we wrap things up, I just want to close with this. We may not have all the answers, but we have the opportunity to do something. If we have the passion, drive, and determination to disrupt, one of my she-rose terms, to disrupt the status quo, and realize that ensuring equity goes beyond equality and must be positioned as an urgent social justice issue, that we all play a part in activating and advancing solutions. So with that, we wrap up, and Leonard, you tasked us this morning with starting on time and finish early. The Fab Five have been a part of that process.